Hey guys, so in this question, we're going to talk about autoimmune diseases, its mechanism, general features, examples of localized and systemic diseases, and rejection of transplants, which is a part of the question. Now, starting with the most simple thing, the definition. What is an autoimmune disease? An autoimmune disease is a condition in which the immune system, our own immune system, mistakenly attacks the body's own cells and tissues. So our own tissues and our own cells are going to get destroyed by our own immune system. How crazy is that? So always start with a very simple definition. Then, after mentioning the definition, we're going to move on to the second thing you guys have to mention, which is self-tolerance. These are the mechanisms which are going to prevent autoimmune diseases in our body. So you have your central tolerance and peripheral tolerance. Very simple. Central tolerance is done by primary lymphoid organs, or you can say central lymphoid organs, which is the thymus and bone marrow. And selection happens here, which is the immature T cells and immature B cells. They go to thymus and bone marrow respectively, and they undergo either positive selection or negative selection. Negative selection and positive selection happens through their MHC receptors. So, for example, they're presented as self antigen in the same organs, thymus and bone marrow, and if they react very strongly, so they're gonna get these immature T cells are gonna get destroyed instantly through apoptosis, because we don't want them going into our body. This is going to create autoimmune conditions, and this point is really important to mention in the exam, that it undergoes selection, and if it bypasses the selection, we're going to get autoimmune diseases. So that's central tolerance, very simple. Moving on to peripheral tolerance, it's just something that's happening apart from these two, thymus and bone marrow. So for example, you have barrier mechanisms, which is like the blood brain barrier, or in the testis where it's separated from the immune system. Interesting fact is that the sperms, they are not recognized by the immune system. So if cells do get from the immune system into the testis, it can attack the sperms themselves. But that's not important. The main thing to remember is that you have your barrier mechanisms, which is blood brain barrier of the brain or in the testis. Energy is very simple. Energy is just that if a lymphocyte encounters a self antigen, so without proper activation signals, it becomes inactive. So it just needs sufficient activation signals. And if it doesn't get that, which it won't, because it's a self antigen, so it will not react, these lymphocytes. Now, suppression is that we have regulatory T cells in our body, which we learned in physiology, and they help in preventing autoimmune diseases. And that's peripheral tolerance, which is not happening in the thymus and bone marrow. Moving on to the next slide, which is the features of autoimmune diseases, starting off with etiology, the causes. So, autoimmune diseases have multifactorial etiology, meaning that they are caused by a combination of both genetic and environmental factors. And environmental triggers like bacterial infection, stress, or other harmful stimuli can activate the immune system. Now, also very important to mention is that in individuals with defective self-tolerance, so the one that we just discussed previously, which is this, if these mechanisms fail, which is central tolerance and peripheral tolerance, and our cells, T cells or the B cells, which react strongly to our self antigens and do not undergo negative selection, and they just pass into our body, they're just going to cause autoimmune diseases. So a very simple way to say is defective self tolerance. And another cause could be having genetic markers like HLA-B27, which could lead to susceptibility to get autoimmune diseases in the future. Affected population is mostly women in their middle ages, and clinical course is relapse and remission, which basically means that during relapse, the symptoms are going to intensify, and during remission, the symptoms subside but temporarily. Morphological changes in autoimmune diseases, generally, what happens is that first you have the tissue is affected, and they may undergo immune mediated destruction to the point of necrosis, which is tissue destruction. And this is followed by infiltration of immune cells like neutrophils and lymphocytes, leading to chronic inflammation. And eventually, chronically, the inflammation causes fibrosis and scarring, resulting in loss of tissue function. And last feature is the mechanism of damage. Damage usually is happening through hypersensitivity reactions, which we have discussed in the previous video. The question, which is there are four types: hypersensitivity reaction 1, 2, 3, and 4. And the mnemonic was acid, ACID. A is anaphylactic because it's involving IgE antibodies, but this is not happening a lot in autoimmune diseases. Then hypersensitivity reaction 2, in which it involves the IgG or IgM antibodies. antibodies targeting the body's own cells, and hypersensitivity reaction 3, which is immune complex mediated and it's deposited in tissues, these immune complexes. And the last one, hypersensitivity reaction 4, which is delayed T cell response, and that basically means that it's a delayed immune response by previously exposed T cells. This is good to know, the four reactions, but in the exam you don't need to mention in detail about this because this was your previous question, it's not this question. So do not mention in detail. It's just mechanism of damage, hypersensitivity reactions 1, 2, 3, 4. Done. Next. The fourth thing, after mentioning the definition, the self-tolerance mechanisms, the features, we come to autoimmune diseases. Autoimmune diseases can be divided into systemic autoimmune diseases and localized autoimmune diseases. Systemic autoimmune diseases, you can mention examples such as systemic lupus erythematosus, which I'm going to tell the details in the next slide, rheumatoid arthritis, Sjogren's syndrome, scleroderma. And in localized, you can divide it into organ system wise, which is CNS, in the GIT, and in the endocrine. In the GIT, you have your primary biliary cholangitis, chronic autoimmune hepatitis, celiac disease. Endocrine, we have diabetes mellitus 1, Hashimoto's disease, Graves' disease. In CNS, you have multiple sclerosis and myasthenia gravis. And guys, all these diseases are going to be mentioned in detail in your special part. So you can mention some points from your special part as well if the examiner asks you about them. And you can even mention more examples because there are more autoimmune diseases. Like in GIT, there is Crohn's, ulcerative colitis. In CNS, there's neuromyelitis optica. So these examples, you can also mention these examples from special. Moving on to the next slide, I'm going to discuss a little bit more about the systemic autoimmune diseases, starting off with systemic lupus erythematosus or SLE. And we know it's chronic systemic autoimmune disease. It's happening through hypersensitivity reaction 3, which is immune complexes are being deposited in tissues. And the antigens over here are generated from poorly cleared apoptotic debris, which is being formed from DNA damage. So when DNA damage happens through UV light, and apoptosis happens in those cells, and that apoptotic debris is not cleared, so those are going to serve as antigens, and the antibodies will be generated against them. So now we have antibodies against these nuclear antigens, and these antigen antibody complexes are the ones which are depositing in the tissues. And when they deposit in the tissues, complement system gets activated, attracts more immune cells or inflammatory cells, and this leads to inflammation. In the next slide, I have mentioned some symptoms of SLE, and you guys can remember it with a very simple mnemonic, which is rash or pain. So let's just discuss it really fast, what the symptoms are. So rashes, which is the butterfly rash, which is a common facial rash, while the discoid rash can leave scars. Arthritis, serositis, hematological disorders, which is in SLE, antibodies can attack blood cells, which is causing anemia, low platelet counts, low white blood cell counts. Then endocarditis, which is SLE, can cause a specific type of endocarditis called Libman sacs involving vegetations on the heart valves. And then we have oral mucosal ulcers. Renal disease is actually really important because kidney involvement is the serious. This can lead to renal failure, and this is the leading cause of death in SLE. After that, we have photosensitivity, which is exposure to the sun can cause rashes. Anti-nuclear antibodies that I mentioned in the previous slide, that patients with SLE often have antibodies against these components of the cell nucleus. And then immunological disorders are also there in is a symptom of SLE, which is anti-double-stranded DNA antibodies, anti-Smith or anti-phospholipid antibodies. These are all present in the patient in SLE. So it's a way of identifying like the markers that this person has SLE. And then we can also see some neurological symptoms in SLE because it can affect the brain, causing seizures and psychosis. And out of these 11 symptoms, if 4 are present, then we can say that the patient has SLE. Next is rheumatoid arthritis. And in this, I'm not going to give you all the details about rheumatoid arthritis in this question, but you should be prepared on what is rheumatoid arthritis, the pathogenesis, and everything. But you do not need to mention it in this question unless the examiner asks you something specific. So in this question, you can just say that it's a chronic autoimmune inflammation, and there's IgM antibodies against the IgG, and this is known as the rheumatoid factor, which is IgM antibodies against IgG, and this is what we detect when we do diagnosis. And these are the immune complexes which are forming, and they will deposit in connective tissue, and this will deposit in the joints, and this will cause pain, disfigurement, morning stiffness, which will improve with activity. And this is obviously hypersensitivity reaction 3. That's it. For this question, you just need to mention one line for each example that I'm saying. Do not mention all the details. This is just for your understanding, or if the examiner asks you more specific details on the question. Moving on to the next, we have Sjogren's syndrome. Sjogren's syndrome is a hypersensitivity reaction 4, which is the delayed response, delayed T cell response. And in this, you have destruction of salivary and lacrimal glands. So you have gland inflammation, and what happens is that you have dry mouth and dry eyes. Dry mouth, also known as xerostomia, and dry eyes, keratoconjunctivitis, Zika. And complications, not important to mention in this question, but it's good to know that it leads to increased risk of Mort lymphoma and Sjogren's syndrome. Next slide is scleroderma. In scleroderma is another chronic autoimmune disease, also systemic, and in this, the disease is leading to abnormal activation of fibroblasts, which are cells responsible for producing connective tissue. That's why we have fibrous thickening of the skin and various internal organs, causing a range of symptoms and complications. The thing that they have written about vasculitis is just that like severe complications can happen in scleroderma, and they're most oftenly due to vasculitis, which is inflammation of the blood vessels affecting blood flow and causing damage to the tissues. Now let's discuss a little bit about the local autoimmune diseases that I mentioned in the flowchart before. Starting off with the GIT autoimmune diseases, it's the same diseases. I just wanted to mention that what the antibodies are produced against. So, for example, in gastrointestinal autoimmune diseases, primary biliary cholangitis, antibodies are against the bile ducts. In chronic autoimmune hepatitis, antibodies are against the hepatocytes. And in celiac disease, we know it's a hypersensitivity reaction 4. There's the delayed T cell response to gluten and gliadin, to be specific. And this causes malabsorption and villus atrophy. Again, you will learn about this in more detail. The next is endocrine autoimmune diseases. As I mentioned, you have type 1 diabetes, in which it's a hypersensitivity reaction where T cells are attacking pancreatic beta cells, and this will lead to high blood glucose. Hashimoto's disease, in which antibodies are against the thyroid enzymes, so thyroxine is not going to be produced, and that's why it will lead to hypothyroidism. And you can also have risk of cancer, neoplasia. And in Graves' disease, it's a bit different. The antibodies are overstimulating the thyroid stimulating hormone receptors, and this is causing hyperthyroidism. The next is in the CNS. In CNS, you guys can mention multiple sclerosis, which is T cell mediated demyelination of the CNS, mostly happening in viral infections. And then we have myasthenia gravis, which is characterized by antibodies targeting acetylcholine receptors at neuromuscular junction. It is important to know what the antibodies are generating against in our body, because the professors will ask you this. Now I brought up this flowchart again because you guys should mention this flowchart. Start with very simple, the definition, talk about self-tolerance, talk about the features, which is the etiology, happens in women, and then you guys need to just mention this flowchart. Autoimmune diseases are divided into systemic and localized. In systemic, we have these 4. In localized, we can divide into organ system wise, which is these, and these. That's it. And you should be prepared on what each disease, the details of each disease, but do not say it. Do not say that, do not start with the details. Start with the details at the end of your question once you're done explaining the basic part. The next part of the question is rejection of transplant, in which you can have 3 types of transplant, like autologous, which is using the patient's own tissue, allogenous from another person, and xenogenic from another species. Graft rejection, I wrote a very simple, like what is graft rejection? Simple line, that is the body's immune system attacks a transplanted organ or tissue because it sees it as foreign, leading to grafts damage or failure. And the reason is HLA or ABO incompatibility, and we can prevent the risk of rejection by trying to match HLA and ABO as closely as possible, or we can use immunosuppressive drugs as well. Next is types of rejection. So we have hyperacute rejection, which occurs within minutes to hours in patients with pre-existing antibodies. They have some kind of pre-existing antibodies against the donor. So this will lead to immediate thrombosis and necrosis of the graft. But this happens like less than 1% of the time. In acute Rejection, it takes place within days to weeks due to T cell or B cell responses against the graft's MHC molecules. Now, this could be either direct recognition, in which the cytotoxic T cells recognize and attack the graft, or it could be indirect recognition, in which the B cells are going to produce antibodies against the graft after interacting with the helper T cells. Last, and this is like 50% of the time. The last is chronic rejection, which is going to like develop over months to years, and this will be like damaging the graft slowly, and especially the vessels of the graft. This can lead to vasculitis and gradual decline in organ function. And lastly, we have graft versus host disease, in which basically the donor's white blood cells attack the recipient's tissues, particularly in immunocompromised patients. There's a high risk in bone marrow transplants due to infusion of donor's hematopoietic stem cells, and also in non irradiated blood transfusions. And what they basically mean by this is that non irradiated blood products refer to blood components that have not undergone the process of irradiation. So, irradiation itself is a method in which we inactivate the T cells of the T cells of the donor. We inactivate the T cells of the donor, and if we don't irradiate it, which is it's non-irradiated, then it can lead to graft versus host disease. And liver transplants, because liver itself consists of many lymphoid cells, so there's a risk of graft versus host disease in the liver. And yeah, that's it.